Good evening, everyone. Once again, a warm welcome to the International Lecture Series on Clinical Nutrition. Today, we're going to cover a topic on nutrition management of diabetes on an OPD setting as well as in hospitalized patients. Diabetes, as you know, has the prevalence of diabetes has increased by leaps and bounds, particularly in Southeast Asia and the Sub-Saharan African region. Over the world, according to the 2021 IDF report, we have around 537 million adults who are living with diabetes. The number is predicted to rise to 643 million by 2030. In 2021 itself, we saw a 316% rise in the health expenditure spent towards diabetes, which is a whopping 966 billion US dollars. Hospitalized patients usually have poor outcomes when they also have diabetes. Diabetes-related complications are very common in people who have uncontrolled diabetes. Once they are hospitalized, if they do not have good glycemic control, it increases the length of hospital stay, leads to poor outcomes in these patients, and sometimes it becomes impossible to treat these patients as well. So it's very important that from the medical nutrition therapy point of view, these patients, while they're outside the hospital, receive good nutrition in order to prevent diabetes-related complications within an hospital as well. They need to have better glycemic control to improve treatment outcomes. Now, before we begin with the session, let me quickly reiterate the rules. The certificate of attendance will be given to all those who attend all 10 sessions, followed by an objective test. Some of you have missed one session, that's fine, we're going to consider that. Attendance for complete session is mandatory for all sessions. Objective test will be a 100 marks test, which will be a Google form. This will be posted in the chat box on 8th of March 2023. So make sure you attend the session on 8th of March. Minimum 80% passing marks are required to pass the test. Feedback for all sessions is mandatory. The feedback link will be posted at the end of the session. Questions can be posted in the Q&A box and will be taken during panel discussion. All comments, suggestions can be posted in the chat box. The YouTube link for all the recorded sessions will be posted today. It will be available to you till the 12th of March, and you need to attempt the exam by the 15th of March. Those of you who are attending through the YouTube link will not be eligible for the certificate. It's my privilege to introduce today's speaker, Madam Ms. Shilpa Joshi, Madam. She is a senior dietitian and founder of Mumbai Health Center. She is going to talk about enteral nutrition for diabetes. Ma'am is a director of Mumbai Diet and Health Center. She's a practicing dietitian of more than 2 decades of experience. She was the vice president of Indian Dietetic Association from 2019 to 2021. Honorary Secretary of All India Association of Advancing Research in Obesity. She's a master trainer in diabetes conversation maps and also the course director for National Diabetes Educators Program. And she's trained more than 3,000 diabetes educators. We are privileged to have you here, ma'am. I request you to start your presentation, please.
Thank you so much, Sukhabar. Just give me a minute to share my screen.
Sure, ma'am.
I hope you can see my screen.
Yes, ma'am.
Yeah, and you can hear me.
Yes, ma'am.
Okay. So, good evening, everybody. Good evening from India. And thank you, Sukhata, Hexagon Nutrition, IDA Mumbai chapter, Clinical Academy for having me here. I also thank my co-panelists, Shraddha Vijan, Bhakti Saman, Miss Christine, and Dr. Sanjay for being here. And let me begin by speaking on enteral nutrition for diabetes management. That's what I'm going to be talking about today. So we know that at least in Southeast Asia, even in Sub-Saharan region, diabetes, like Sukhada said, is something which is ubiquitous. There are a lot of people with diabetes, and these people with diabetes tend to fall ill critically or otherwise and get admitted to hospital. And then there is a different way in which you can manage. My talk also has a section in which we are going to talk about enteral nutrition or diabetes specific nutrition, as we call it as DNS. which you can give to prevent or delay the progression of diabetes. So in the beginning, I'll be talking about hospital-based enteral feeding, and then I'll be talking about diabetes-specific nutrition, which can be given as a preventive modality to prevent diabetes or recurrence of higher blood sugars in individuals. So I think these are a couple of things which you have been hearing for last couple of weeks. But just to begin my talk and to give it beginning, I'm going to talk about what are some salient features of enteral nutrition and some, smaller aspects of nutrition before I actually get into nitty-gritties of what you do with diabetes-specific nutrition. So enteral nutrition is beneficial to individuals who have functional guts, and but these individuals are not able to meet their nutritional requirement via normal diet, and this can be in case of individuals with stroke, cancer, surgery, or even in individuals with failure to thrive. Enteral feeding can be delivered by a range of feeding tubes through different methods of feeding, including continuous feeding, bolus feeding, and gravity feeding. I think in diabetes management, this becomes extremely important. Nasogastric tubes, which is also called as NGT feeding, is often provided to individuals requiring a short-term enteral nutrition provision. And for a long term, there is a PEG tube, which is put for the long-term enteral feeding. So say somebody is discharged on enteral feed and you are looking at a long-term enteral feed scenario, then in this case, having a nasogastric tube is not sufficient, because a lot of times, to keep in the nasogastric tube becomes difficult. And in such individuals, then PEG tubes are often used as a feeding modality. Now, what does enteral nutrition actually entail? So nutritional status assessment and evaluation of nutritional requirements or need of the patient. So when you are planning enteral nutrition, you need to think about this. You need to understand nutritional status. So you need to assess nutritional status and evaluate what would be nutritional requirement of this patient. Development of feeding regimes, which includes protocols, guidelines, algorithms, and management of patients or the pump, feeds, or feeding tube. So this is something which is important. Now, enteral nutrition can be it can be broadly divided into three parts, which is hospital-based, again, hospital-based or critically ill. Lot of patients are even discharged on enteral feeds, like I told you. So we are looking at discharged patients on enteral feed, and then non-critical patients, ill patients at home to manage their blood sugars. And also a lot of times, especially in case of individuals with type 2 diabetes, along with managing blood sugars, and along with managing weight, we also manage blood sugar. Now, what are the issues of dietary management of hospitalized patients with diabetes? Deciding the feeding schedule, that is matching the insulin or oral regime with feeds. And this is essentially the fulcrum on which a well-planned feeding regimen stands. Decision of calorie and macronutrients. And when in macronutrients, while planning a feed for an individual with diabetes, you're essentially going to take care of carbohydrates, because carbohydrate is a nutrient that is going to impact your postprandial blood sugar control. And as it is in individuals who are hospitalized or are critically ill in ICU, because of various other factors, their blood sugars are high. So maybe the counter-regulatory hormones are high, gluconeogenesis is higher, so on and so forth. So these problems actually lead to very fine matching of carbohydrates with the therapy given. Very important nowadays, the studies have shown that glycemic variability between the feeds, or in general, in simple terms, we would say prevent highs and prevent lows. So glycemic variability, or GV as it is called as, it is the length or it is the distance between the highest blood sugar and the lowest blood sugar. So if there is more variability, there are more peaks and valleys, you will see that the rate of complications are higher. And hence glycemic variability is very, very important when you are trying to manage a hospitalized patient with diabetes. Selection of oral nutrition supplement, that is ONS itself, if it meets other nutritional requirements like protein, fats, and micronutrients. ONS can also take off complications with managing diabetes. So for example, Individual with diabetes can have chronic renal failure. So say you need, electrolytes, a supplement which is lower in electrolytes. Or say they have gastroparesis, then you need a supplement which is lower in fiber. These are just two examples. There are many such. What are the challenges with enteral fees? The main challenge is funding or cost. Inadequate lack of standards, policies of the hospital, management approaches, guideline, and infrastructure for delivery of enteral nutrition. Now, speciality of diabetes specific enteral formulae. So, malnutrition is seen in several patient groups with diabetes, especially in case of elderly and those with complications such as renal failure or even neurological dysfunction because of other reasons. Like, if neurological dysfunction can include gastroparesis, where gastric emptying is impaired, or somebody is having diabetes bound diarrhea, such kind of neurological dysfunction can impact blood sugar management and also can impact nutritional status and cause malnutrition. Impaired nutritional status is associated with increased susceptibility to and recovery from infectious complications, and even in development of pressure sores in case of individuals who are bedridden for a longer period of time, and in general functional decline. Nutrition support using diabetes specific formula in these patients may prevent such complications. Now, what is the speciality of diabetes specific enteral formula? So standard enteral formula, that is either whether taken oral or taken by a tube, are usually high in carbohydrate and low in fat and low in fiber, usually, although there are specific ones which are not. Standard formulas tend to compromise glycemic control in patients with diabetes due to rapid gastric emptying rate and therefore rapid nutrient assimilation. That means what? You take the formula, you get an immediate 1 hour high or maybe even high at 1.5 hours because the emptying rate is fast. See, liquids empty out faster than solids. Food lower in fat and fiber empty out faster. If the formula is not diabetes specific, if the gastric emptying is faster, you will see that there is rapid assimilation of nutrients and that leads to peak, which increases glycemic variability in individuals with diabetes. Diabetes specific formula contain a defined nutritional composition designed to better glycemic control. Such nutrients include fructose, fiber, MUFA, soy protein, and antioxidants. Although general guidelines exist regarding composition of diet for those with diabetes, there are no specific guidelines for patients with diabetes who are at risk of malnutrition and requiring nutritional support. So if you look back at guidelines, really very few guidelines which are specific for individuals with diabetes who are at risk of malnutrition, because more often than not, when you meet diabetes, you think of an individual who is higher body weight, higher BMI, more fat percentage. So you don't think of malnutrition as much as otherwise. Although general guidelines suggest that high intake of MUFA or total fat may be disadvantageous for well-nourished patients with diabetes, this may be actually advantageous for treatment of malnourished individuals. Why? Because there is only little carbohydrate that you can give because there is hyperglycemia present. So it is a toxic environment to give further more carbohydrates because they already have high blood sugars. So in such cases, additional amount of MUFA can actually change the dynamics of how blood sugar is getting controlled. Now, diabetes specific enteral formula, what are the blood sugar related advantage? So there is a systematic review of 19 randomized controlled trials, 3 CCTs and 1 CT showing that use of diabetes specific compared with standard formula given as oral nutrition supplement consistently results in significant lower PP rise in blood glucose, peak blood glucose concentration and glucose area under the curve in patients with diabetes. This was achieved without evidence of hypoglycemia. Now, here is where I talk about glycemic variability. See, a lot of times at the end of 3 months, you may have a great HbA1c, and that is a very good thing. But the point is, if you have high blood sugars and low blood sugars in equal amount, the A1c still can be near normal. But the variability is so much that you are going to have a lot of complications associated with it. When you give the right nutritional formula with the medication, right kind of medication, whether insulin or whether OHA, what you achieve is least amount of glycemic variability, in which, in case of individuals who are critically ill or older adults or younger children, hypoglycemia becomes a very important predictor about how the patient is going to, progress. Higher fat and fiber in the formula could facilitate glycemic management by delaying gastric emptying, delaying intestinal absorption of carbohydrate, and producing smaller glycemic response by giving fructose. Now, this is for people who are still in the hospital. Now, once discharged on enteral nutrition, home enteral nutrition, HEN is home enteral nutrition, which is indicated. So these are indications and these are contraindication. Most of the home enteral nutrition should be offered to patients at nutritional risk or malnourishment who cannot meet their nutrient requirement by normal dietary intake and who have a functional gastrointestinal tract, definitely. Prior to discharge from the hospital of the patient at risk of malnutrition, okay, either oral nutrition supplement or home enteral nutrition should be considered. These are indications. Now, what are the contraindications? If the life expectancy is estimated to be less than 1 month, then home enteral nutrition usually is not initiated. Home enteral nutrition shall not be, pardon me, shall not be performed in patients with contraindications such as severe disturbances of the bowel, GI obstruction, gastrointestinal bleeding, so on and so forth. And if the patient and or their legal carers do not agree with home enteral nutrition program, or are unlikely to comply to it, then you will not, they are not advised for home enteral nutrition. Now, what is the delivery system? So if it is a less than 6 weeks, so if they are predicting that home enteral nutrition will be required for 6 weeks, then you can have a nasogastric feeding tube in such cases. But if it is long term, more than 6 weeks, means more than month and a half, then a PEG tube should be considered. And because long term, more than 6 week use of a nasogastric tube becomes very, very difficult. Okay, so these are which are products which are recommended for home enteral nutrition. So again, standard situation, standard commercial formula can be used for patients without diarrhea, constipation. Standard commercial tube feeds can be used for special situations like diarrhea, like constipation, and diabetes. You will have specific formula. So diabetes, you'll have diabetes specific formula. For diarrhea, you will have fiber containing feed shall normally be used, and for constipation also fiber containing feeds will be given. But we are only talking about diabetes related and home enteral feeding. And termination, home enteral nutrition should be terminated when a desired weight has been reached or patient's oral intake matches his or her maintenance need. So soon patient starts eating orally and you see that now patient is no longer losing weight, probably gained a little weight, is looking better. When you take a recall, is much better. Then, and if they have started eating well, then home enteral nutrition can be terminated. Now from there we switch gears and we go to DNS, that is diabetes specific nutrition or meal replacement products, which are designed with type and amount of carbohydrate and other macronutrient composition to provide quality nutrition while minimizing impact on postprandial glycemic levels. This is very, very important. The key word here is postprandial glycemic levels. Several studies have shown that in addition to effect on serum glucose, diabetes-specific nutrition or meal replacement products have a unique benefit on important gastrointestinal and pancreatic hormones such as insulin, GLP-1, and on serum free fatty acids, which mediate glucose metabolism and insulin sensitivity. Several studies have shown that use of diabetes-specific nutrition to replace 1 or 2 meals as per intensive lifestyle intervention significantly reduces HbA1c and reduces the need of medication in individuals with type 2 diabetes. Okay, so there are various treatment options available when somebody is recommended diabetes-specific nutrition. So in obese or overweight individuals who are on low-calorie diet, there are high chances of micronutrient, vitamin and mineral deficiency when they are on energy-reduced diet. Various clinical studies indicated that increasing either soluble or insoluble fiber increases post-meal satiety and decreases subsequent hunger. Meal replacement therapy, that is replacing 1 or 2 meals a day, is a viable approach for combating overweight, obesity, and also looking at diabetes remission, if at all, as a possibility. Now, there are protein shakes available and there are meal replacement available. And a lot of times, one is confused with another. And therefore, one has to understand these are two different entities. If you're replacing a meal as a DNS, you're replacing a whole meal, then you need to use a meal replacement. Whereas if you're trying to bridge the gap between protein intake, then you need to give protein shakes. So just for benefit of everybody, I have separated this two. So what are protein shakes? Intended to supplement a regular diet and not to replace a meal. So if you are using a protein shake, you try to supplement it to the regular diet. Say a patient requires 60 grams of protein. Through diet, you can meet only 40, then that gap of 20 grams can be met by protein shake. To be consumed, say, before or after workout, typically 25 grams of protein per serving, usually have less than 5 grams of carbohydrates, since they are not intended to be full meal. So they are not a balanced meal at all. Tend not to contain any added vitamin or mineral or those other than those provided by the protein source. As opposed to that, what is a meal replacement? It is intended to substitute 1 or 2 meals of your daily diet. It is usually fortified with vitamins and minerals. They offer fiber, carbohydrate, and calorie per serving than the protein shake, although they are in lower calories than actual meal. So say your normal meal is 300 or 400 calorie. You're trying to replace it with a meal replacement, which gives you about 200 calories. Provides protein, but at a lower level than most of the protein shake, and one cannot be used instead of other. So somebody's taking to meet a protein gap, then you cannot take a meal replacement. If somebody's trying to replace a meal, you cannot give a protein shake. Nutritional adequacy of use of supplements. So you can give them to fill a protein gap, to have a favorable amino acid profile, to fill in micronutrient gap, to limit eat out option, lower in calories as compared to other food options, ensures bioavailability and caters to specific needs. So now this is meal replacement therapy. You are substituting 1 or 2 regular solid meals or snack. I am a big fan of snack replacement, but there are a lot of people who are happy with meal replacement as well. My personal opinion is people do not go wrong when they eat breakfast, lunch, and dinner. Generally, they don't. They try to eat balanced meal. They try to include vegetables, meat, or pulses or legumes, a source of carbohydrate, and lot can be taught to them, or a lot of solutions can be given to them when they want to eat main meals. What happens is at 5 o'clock, when you feel very hungry, you don't know what to eat. Whatever meal you carried with you to your work has gotten over. And then you go to your office canteen, or you go down and see if you're getting some kind of food to eat, which is usually deep fried or sugar laden or packaged. And then because you're so hungry, you just eat it. And then you find that your blood sugar control or your weight management all goes out. And in such cases, you can give meal replacement therapy, which takes care of your hunger, satiates you. At the same time, it helps you to manage your blood glucoses very well. It provides nutritionally balanced, low fat, low energy. So there are 2 kinds of meal replacement therapy: total, where you are replacing all 3 meals, and partial, where you are replacing either 1 meal or 1 snack. Okay, so there are 2 kinds of meal replacement, again, very low calorie and low calorie. So very low calorie is less than 800 calories per day. The one which was given in the direct trial, direct trial is a UK-based trial for remission of diabetes, where individuals were kept for first 3 weeks on VLCD, very low calorie diet. And they actually showed that when individuals lost 5 to 10% of their original body weight, there was remission of diabetes. A lot of people lost their liver and pancreatic fat, as it was seen on MRIs. So VLCD has become very popular since then. But low calorie diet is a diet greater than 800, but about till 1200 calories. Okay, so low calorie diet can be given instead of a reduced low calorie diet can be given with the traditional low calorie plan, that utilizes a food regime, a meal plan of pre-packaged food, snacks that are vitamin and mineral fortified, a partial meal replacement plan where there are 2 portion controlled meal along with a mineral and protein fortified meal replacement shake as one of the meal. So total meal replacement can be used if you at all want to use. You can use it to kickstart a weight loss program. So say somebody who is say BMI, about 30 maybe, or 35 is coming to you and they want to see the scale going on other side, to get motivated. And that's the time you can use total meal replacement program. But remember, it can be used for a very short time. So in direct trial, total meal replacement was used for 1 month, that is 12 to 20 weeks. And total meal replacement, of course, is used in post-bariatric surgery. Partial meal replacement, one or more meal replaced by commercially available calorie reduced products that are fortified with vitamins and minerals, and at least one meal consisting of regular food is something that a partial meal replacement program asks. So why I told you why partial meal replacement, because it can be a part of a structured weight loss program. It is extremely safe. Like I said, it, lot of times takes the load off patient when they have to make a decision as to what to eat. Like I said, typically breakfast, lunch, and dinners are not a problem, but a lot of times snacks are a problem. People who, travel a lot for their work, they do not have time to sit and eat a breakfast. So meal replacement can become breakfast, whereas they're okay eating lunch and dinner, somewhere, or they come back home for lunch and dinner. So things like that. So work around your patient's schedule and see which meal is one which is a problem meal, and those 2 meals can be replaced. So meal replacement are safe and effective approach for achieving significant sustainable weight loss. It improves biomarkers of metabolic profile in overweight, obese individuals, and in obese cases associated with type 2 diabetes and PCOS, that is polycystic ovarian syndrome. Studies indicated that meal replacement is a more effective measure for reducing body weight loss maintenance as compared to low calorie meals itself. So what are the specific needs? What do I eat now? There is no need of milk or any fancy equipment. So first of all, it limits food choices. Nobody has to think what to eat. It is very easy to use. You just need water. Taste is great of most of the meal replacement shakes. And there is ease of availability. It's available everywhere. What are other therapeutic uses of DNS? So one of the most important use of DNS is use in reactive hypoglycemia. So what is reactive hypoglycemia? Reactive hypoglycemia is a condition of postprandial hypoglycemia that occurs between 2 to 5 hours after food intake. So reactive hypoglycemia is clinical seen in 3 different forms. Idiopathic, that it happens around at 180 minutes, elementary within 120 minutes, and late RH between 240 and 300 minutes. When first phase of insulin response decreases, that is what happens in type 2 diabetes. Firstly, blood glucose starts to rise after the meal. This leads to late but excessive secretion of the second phase of insulin, and then the late reactive hypoglycemia occurs. Elevated insulin levels also causes downregulation of insulin host receptors on the muscle and fat cells, and thus decreasing insulin sensitivity. So what do you do in reactive hypoglycemia? You give a protein-rich meal. Avoid plain carb meals. These are Indian examples, but anything which is rice-based like poha or upma or bread, which is simple carbohydrate, all this will cause a lot of reactive hypoglycemia. If at all, accompany them with lots of proteins like sprouts, eggs, curds, meat, whatever you can. Fiber will delay gastric emptying and prevent dipping of blood sugar. Hence, you include salads or sabzis or sprouts to help it. Low glycemic index foods are great choices. So maybe sattu in water, chilla, sprouts, all of these are Indian things which are made from pulses. They can be used. Diabetes specific nutrition and meal replacement can help tackling with reactive hypoglycemia. Another place where it can be used is Somoki effect and Dunford. So what is Somoki effect? It happens when your blood sugar can drop sharply overnight. Your body responds by releasing hormones that work against insulin. This means you will have too much blood sugar in the morning, and this is called as rebound hyperglycemia. So Somogi effect, first you get low blood sugar and then you get high blood sugar. That is why 3 a.m. blood sugar becomes important. dawn phenomena. If you have diabetes, your body doesn't release more insulin to match early morning rise in blood sugar because of counter-regulatory hormones like growth hormone. It happens in dawn, that is around 3 a.m. and usually between 3 a.m. and 8 a.m. And this is called as dawn phenomenon. Now, how do you differentiate between both? How do you know whether it's somoggy or it's dawn? So to know one from another, do a 3 a.m. blood sugar. If it is low, then it is somoggy effect. If it is not, then it is dawn phenomenon. Do this test when you see recurrent high fasting blood sugars despite of changes in diet. Now, what will you do? If it is somoggy effect, you want to give a diabetes specific nutrition at night so that your blood sugars do not dip at 3 a.m. Okay, if they don't dip at 3 a.m. because of if it is because of somoggy effect means blood sugar has to dip around 3 a.m. It will not dip because you have given a protein-rich DNS, diabetes specific nutrition at night, so that your blood sugar is steady and same level throughout the night and you will not have a problem. So for somoggy effect, it's very important that you start diabetes specific nutrition at bedtime. So bedtime DNS is a must for somoggy effect. Bedtime snacks should contain lentil carbohydrate and a mix of carb, protein, and fiber. Many drinks are available to prevent it. And if at all there is excess insulin or OHA, you want to adjust those doses talking to the doctor. For dawn phenomena, you can't give DNS. So what you need to do is do not eat carbohydrate loaded meals at bedtime. So if you're eating too much rice, too much roti, too much bread, try not to eat it. See to it that there is enough fiber and protein in the meal. So include a fiber and protein source at the dinner. Take insulin before bedtime instead of earlier in the evening so that it will last you throughout the night. Ask doctor about adjusting dose of your insulin and other diabetes medications. So in conclusion, nutrition plays a role in preventing and management of metabolic disease. Malnutrition is associated with uncontrolled blood glucose due to glucosuria, catabolic hormones associated with hyperglycemia. Selection of right feeds with right nutrient composition and delivery of these at right time plays a major role in pushing patients to recovery and initiate anabolism. Studies also have shown remission of diabetes using low-calorie meal replacement. Judicious use of diabetes-specific nutrition can help to prevent short-term and long-term complications. Thank you so much for a patient hearing, and I'm happy to take any questions that you have.
Thank you so much, ma'am. I think this was like a refresher course in diabetes itself, and you've covered every aspect that a dietitian needs to consider when planning a diet for people with diabetes. Without wasting any more time, let me quickly call upon the panel as well, and I would like to request our moderator for today, Ms. Shraddha Vision, to moderate the panel. But before I do that, let me quickly introduce her. Shraddha is a registered dietitian with Indian Dietetic Association and also a LEC member of IDA Mumbai chapter. She's a senior dietitian at Bombay Hospital and MRC in Mumbai and has over a decade of experience. She has a master's in clinical nutrition and also is certified in nutrigenetics and FODMAP as well from Monash University. She's involved in various research projects and her keen interest is in GI and critical care nutrition. Over to you, Shraddha.
Thank you so much, ma'am, for your kind introduction. So I would definitely agree with Sukhada ma'am when she said that it was an absolute refresher course what ma'am had gone through in the entire PPT presentation. And going to another interesting session, that is our panel discussion, I would like to invite our other panelists for today. I would request Shilpa Joshi ma'am to stay back because she is our first panelist. As ma'am had introduced her earlier, ma'am, please welcome. You're welcome for the panel discussion. We have also, thank you, ma'am. Miss Christine Muturi. Please apologies if I have mispronounced the name. She's a senior assistant nutrition and dietetics, Kenyatta National Hospital. She's also a licensed nutritionist, and she has a vast experience in clinical and community nutrition. And she currently works as a senior assistant nutrition and dietetics at the Kenyatta National Hospital. She has keen interest in nutrition and health research with a focus on collaborative approaches to healthcare. We welcome you, ma'am.
Thank you so much.
Going forward, we have Dr. S.M. Sanjaya Hiti Gidara sir. He is a graduate chemistry B Pharma, also MSc in food and nutrition, and so has a lot of certifications that he has done. Efficiency as a pharmacist and a registered pharmacist. He's also a dietitian issued by the Ceylon Medical College Council and are registered as a nutritionist by the Sri Lanka Medical Council as well. Sir is also a faculty of graduate studies in University of Kelaniya from 2016 to date. He's also got a Master's of Science degree, that's MSc in Food Science and Nutrition. And he's got a huge experience of more than 35 years in the field of hospital and community pharmacy. We welcome you, sir.
Thank you. Yeah,
And thank you, sir. Going forward, we have Mrs. Bhakti Samant ma'am. She's the chief dietitian of Kokila Ben Tirubai Ambani Hospital, Mumbai. She's also the honorary joint secretary of Indian Association of Parenteral and Enteral Nutrition, which is IPIN Mumbai chapter. She holds a master's degree in dietetics and also a registered dietitian. She's also a European ESPEN diploma in clinical nutrition and a chief coordinator for ESPEN Training Center, KDH. She has a lot of affiliations to different associations and holds a lot of certifications as well. We welcome you, ma'am, for this panel.
Thank you.
Thank you, everyone. So taking the panel discussion forward, we've got some very interesting questions for the panel. So let's start with the first question with Shilpa, ma'am. Ma'am, as there are many diabetes educators also in this group today. So we have this first question, which is directed towards you, that apart from HbA1c, what other assessment tools or rather dietary modifications can a diabetes educator can use in order to ameliorate the different complications that we see with diabetes? If you can give your inputs, ma'am.
So this is for hospitalized or regular patients?
Ma'am, for both. If you can touch upon both the topics, it would be great.
So more and more research has shown. So if you even look at the ADA standard of care now, or you even look at any kind of research, lot has been spoken about glycemic variability. So now HbA1c, yes, it's an important marker, and we all know HbA1c is average. So 5 highs and 5 lows together make a wonderful HbA1c, but the patient is still going to get complications. So what is very important is the peaks and nadirs which happen all the time. That actually shows how fast your patient is going to get microvascular complications. And we know microvascular complications are detrimental. And therefore, what we want is, we want patients, so CGMS is one great device where you are going to know what is the variability and which can help you to titrate the blood sugars, what you are eating. So for example, I eat 2 chapati, dal, sabzi, and my say pre-meal sugar is, let's say 150, and my post-meal becomes 250, then I know that whatever I ate was too much. And in this case, probably 2 chapatis was what I did not need, and probably 1 chapati with more dal and more sabzi is what I need to reduce the variability between a pre and a post meal. So I think glycemic variability is one such indicator which we can use. But if you don't have a CGM, for example, what happens, because not everybody has a CGM, it's important that you monitor your blood sugars with SMBG. Glucometer is something that you have, whether you are at home or you're hospitalized. And if you start seeing the delta, and what is the delta? The difference between a prandial and a pre-meal sugar. And if your deltas become large, you know that the glycemic variability is huge. And I think that is something that you do not want. You want your blood sugars to, they won't come in a straight line, but they can come as very gentle peaks and curves and not Mount Everest. So that is something that we want to speak about. So that is one of the indicators, but other indicators can be other things like weight, loss of, visceral fat. So if you're doing a waist to hip ratio, that's a great indicator to know how well your blood sugar is going to get controlled later on, how well your insulin sensitivity is going to improve. So if you're looking at individuals with pre-diabetes, more importantly, women with say PCOS, then you are looking at other symptoms, acanthosis nigricans, decrease in it, acne, hirsutism, other things you can look at. So there are many indicators. So like it said, different strokes for different folks. So different things can be an indicator for different kinds of individuals. So while in hospital, there are different indicators. In individuals who are not hospitalized, the indicators can be completely different. But I personally believe glycemic variability is a great indicator to know where your blood sugar is going. Thank you.
Thank you, ma'am, so much. That in our today's scenario, when you see patients, this variability is something that earlier, which was not so much looked into. But ma'am, I have this one query also. In case if the patient is belonging to a low socioeconomic strata and they are unable to do this blood sugar checking, so in this patients we generally face a lot of challenge to actually monitor their this variabilities also. So what tips or tricks can you give us in managing these patients?
I feel like, when the patient is in the hospital, that is a time you can use to standardize a meal. Because in hospital, by default, because say they are given insulin or whatever, they're changing OHA or something,
True.
It is done. So you use that time judiciously to come down to a carbohydrate ratio. See, in Indian meals or any agrarian kind of diet plans, where there is a lot of emphasis on carbohydrate, as long as you can fix it, if instead of eating one bowl of salad, if you eat 4 bowls, sugars are not going to change much. But instead of eating one chapati, if you eat 2, sugars are going to dramatically change. So as long as you can fix carbohydrates while they are monitoring, because they are not going to monitor for long. So you can fix sugar, carbohydrates, and then play around with other nutrients as and when or like they are cooked at home. But this is only good for individuals with type 2 diabetes. In type 1 diabetes, this does not hold true because they're very brittle in nature. So what happened in hospital is gone. Now what happens at home is a completely different story. And unfortunately, there is no way out. I personally feel, and I may be wrong or I may be biased, but I feel like complications are way more costly than glucometer strips. So if you get an admission to hospital, glucometer strips are peanuts in front of that. So I think, there used to be an ad long back, अच्छी चीज खरीदने में और सस्ती चीज खरीदने में फर्क होता है, ललिता जी, So the thing is, you have to know where to spend money.
Right.
So if you can, I know it is expensive. There are no two ways about it. But if you can, get your blood sugar fluctuations in control, you will see long-term decrease in hospital admissions, long-term decrease in rate of hypoglycemia, which can itself lead to a hospital admission in older adults or in younger children. So it really depends how you look at the whole problem, because this is going to cost money. It depends where you want to spend your money. So strips and good amount of medication and right diet, or then getting admission to hospital.
True. Very, very, very valid point, ma'am. Actually, it's very valid that counseling these patients regarding this factor of cost, where exactly they want to spend and how they want to spend, becomes so important, even for the diabetic educator, because when they come to them, that is something that they need to explain it to them. Thank you so much, ma'am, for such a valid point. Taking it forward to Bhakti, ma'am. The next question is for you, ma'am. as we were speaking about this, the variability that we see in the admitted patients as well for the blood sugar levels, specifically as a clinical nutritionist, because we also work in the hospital, sometimes even if the patient has been put on a diabetic diet that we normally say, or if the patient has been started on a diabetic specific formulation, and still the patient is having high blood glucose levels. So in this case, how do you manage these kind of patients in changing their diet patterns or in the counseling terms? If you can give your inputs on that.
Yeah, thanks for that question. Just to add on one point, what Shilpa very nicely explained about the SMBGs, that is the glucometer readings that we are telling the patient to monitor. One of the things which I've come across most often is there are patients who are diligently checking, but they will always end up checking only the fasting and be in that thing that, oh, my fasting is absolutely normal. I don't know why my HbA1c is high. Or they will check only, say, post dinner, or they will check only, say, one particular report standard. So I think counseling these patients that even when you're doing a glucometer reading, instead of doing multiple pricks on one day, when we give them a chart, what we emphasize on is do only one reading in a day, but every day do a different reading. So you know how the sugars are fluctuating. If you have titrated your intake, the composition of the meal is standard, which you have told the patient what to follow. Now you are seeing that after eating those meals, how throughout the day the blood sugars are fluctuating, where we are not able to use a CGMs. So I think that was one point which I wanted to add on, which I think most of the time when we have to tell the patient, and then that is when we come to know why there is a variability, what time there is a variability, and do a modification. Coming to your question about hospitalized patients, I think as dietitians, there are varied. I mean, there's a crowd of more than 200 people right now. I can see a lot of names where I know are working in hospitals. But what I see is that with each center, it will be different. When you're looking at a government hospital versus a private hospital, now challenges will be different. When I'm looking at a private hospital experience, yes, we have standardized meal, we have cyclic meals that we are going to give to the patient. Now, based on the glycemic variability, we are going to do a modifications in the meal plan. But we are more towards patient satisfaction. We are treating the patient clinically, but at the end of the day, you have to provide what the patient needs or is demanding for. So I think somewhere few challenges that we face, that even after giving an excellent diet plan and doing an excellent menu planning in the hospital, we still see that there is a variability, especially in ward. See, ICU, I still know that it's going to be monitored pretty well when you have a 1:1 ratio of the nurse and the nurse to the patient ratio, whereas in the ward there are relatives visiting, each one feeling my patient is not eating enough. You must have calculated the carbohydrate and divided very excellently throughout the day, but the patient is not eating those meals as per the timings provided. And sometimes it so happens that there is a mid-meal provided to them that the patient was supposed to eat at 11. Post that, say after 1.5 hours or so, that the lunch was going to be, given to the patient. Many a times the patient would not take that meal and would club it with a lunch meal. So these are very common things, and we keep wondering as to what wrong diet did we provide that the sugars have increased.
True.
So I think going a little in detail about the timing, whether the patients are abiding by the meal timings that you are providing, whether they are eating the meals as per the meals that you have provided. And when you talk about ONS, now this is my experience, we counsel the patients very, very specifically as to whether it is 2 scoops BD or 2 scoops TDS, whatever is the dose that you would have prescribed. What we need to emphasize is in terms of the timings. Okay, at what time of the day are you going to have the ONS? Because most of the time you will see patient, even when they come on an OPD basis, even though when you have counseled them, along with the breakfast, they will take the ONS, or along with the tea time, they will take an ONS, where they have already taken maybe a 150, 200 calorie meal. And on top of that, they have, added an ONS. So even if it is a diabetic specific formula, if not taken at the right timing, where you wanted to give those in between meal timings or a evening snacking or maybe a mid morning or maybe a bedtime, if the timings are not correct, is where you are going to see, even after a right prescription, that there is going to be a glycemic variability. So I think these things we need to pay a little extra attention. We need to be more specific about what prescription we are giving, and be more specific even in terms of writing the timings of when to administer what and when not to take. So I think these things we need to emphasize more in detail.
Absolutely, absolutely, ma'am. You very correctly pointed out this. The main golden word over here is the timing. You have given the best, but if they are not following or adhering to the timings, it actually goes for a complete toss. And in a very practical setup, the moment sometimes, you start with the supplementation and the sugars fluctuate and you are held up, that what did you start that caused the fluctuations. So I think as a nutritionist also, we need to be very clear about our timings, about our rationale for giving that supplementation, and then we are in a good position to actually defend it also.
Yes.
That it's for the benefit of the patient.
Yes.
It's a very practical point, ma'am, actually, to be honest with you, because in the hospital this is the scenario that we see. So taking it forward, as we had discussed earlier also about the different complications that develop because of diabetes. So my next question is to Dr. Sanjaya. So also diabetic gastroparesis is something which is as a complication that we see in diabetic patients as well. So in selection of specific supplements, what do you actually see in that supplement, or what component do you consider when we are managing patients with gastroparesis, probably some very advanced cases that might need a gastrostomy feeding in future as well? So what is your criteria that you will consider for these patients?
Yeah, thank you very much. That question is very important because the diabetics is a chronic disease condition. It's going lifelong. Therefore, time to come, there will neuropathic problem will come out even for the gastrointestinal system. Because of that, gastroparesis is a chronic disease disorder for this population. Also, is characterized by the delayed gastric emptying. If there's no any mechanical obstruction in the gut system, that is normally you can see those patients nausea and then postprandial fullness, vomiting, and so many upper abdominal pain and so many things. For that one, actually, for those patients, before selection of the specific nutrients is very, very challenging for these gastroparesis patients due to incomplete understanding, and at the same time limited therapeutic option. For that one, eventually we need enteral nutrition for these patients. Sometime even for the following stepwise treatment approach for this, including diet and sometimes prokinetics like metoclopramide and gastric rest and jejunum peg feeding to complete rest for the stomach. Then for this one, now see completely different from my idea is completely different from the formulation selection for this category of patients, because now you see in the diabetic specific formulas normally contain more than 40 up to 40% of around fat content and high fiber. Then it will that is specially designed that particular product for the gastric delay to avoid the absorption and slow the postprandial glucose level, not to increase. And at the same time, for this particular one, the delay in gastric emptying, delayed gastric emptying. Therefore, I think for this population, we have to select other way around the nutrition supplement for enteral feeding for these patients. I think therefore for these patients, then because we have to be very carefully select the nutrition supplements. that means low fiber and the maybe low carbohydrate also, not the very complex one. Therefore, at the same time, we have to use the insulin maybe time to time, very frequently, depending on the type of feeding pattern. Maybe sometime, peg feeding, bolus feeding, or prolonged type, maybe continuous feeding patterns or whatever. Therefore, depending on the situation only, we have to dietitian has to select the correct formulation.
True, sir. True, sir. It's a very tricky and a challenging condition in these, because you really, what you very correctly, sir, pointed out is we have to look at the other way around. Because when we focus so much on giving them high fiber and everything, but they already have the gastroparesis into picture, so we have to have a very different perspective towards managing them as well. So thank you so much for that input. Taking it forward again on the lines of the complications that we see with diabetic patients, in a very practical aspect, again, in admitted patients also, as well as on OPD basis also, that we see is patients can sometimes come up with diabetic foot ulcers. That's one very, very common scene also that we see in these patients. So my next question is to Ms. Christine ma'am, that in these patients who have diabetic foot ulcers, have you seen any use of immunonutrients, specifically the use of glutamine or something like zinc or selenium? What is their benefit for these patients? And any practical experience that you have with the use of these nutrients in this specific group?
Thank you so much for that question. It is well known that our immunonutrients, especially the glutamine will help in increased collagen production, will also help in just simply in controlling, in helping in increasing insulin sensitivity, hence controlling blood glucose. So our patients are more likely to have better wound healing. So in our setting, we have seen anecdotally in our experience that when we prescribe glutamine supplementation in some of the patients, we find that the wound healing is better. You actually can see the wound drying up a little bit faster in the patients who have received immunonutrition than in those who have not received immunonutrition. That being said, there was a point that had been if I may go back, whatever we had spoken about in terms of the diet and the meal timings. Sometimes we find it very useful to have extremely specific practical guidance, in the sense that we in our setting, when we're talking about how the meal timings, when you say have your tea time, have your snack, in our setting, snack means tea and something else. And I know it is the same as in India. So when we have tea and something else, you find the blood sugar levels will definitely come up. So we tend to even limit the snack options to just have one snack item. So the person, if you're presented with 2 items, they will always pick one. If they didn't finish their meals and the 11 o'clock tea or 10 o'clock tea has met with their lunch, then now they are not allowed to have the 11 o'clock tea. So it makes it a little bit more practical for the patient to visualize and see when they're allowed what. In regards to the SMBG, we also again try to, I've seen it's in good practice, what you were talking about, having them monitor different readings at different points. And in our institution, in our outpatient clinic, the advice that has been given consistently has always been to divide, if your clinic is 4 weeks apart, have 1 week where we just take after breakfast.
Okay.
So we take fasting. The fasting blood glucose is always compulsory, and then after breakfast for the whole week. Then the next week we'll always do it after a snack. The next week we do it after lunch. So by the end of the 4 weeks, we find that our patients, when they come, are able to really point out and say, this is the thing that causes my blood sugar to go up. They're able to track it safely, especially when they have been cancelled on the importance of that. That together now with diabetes specific supplementation where need be, and together again when need be with the immunonutrition, then we have seen very better levels, good levels of success. Thank you.
Okay. Thank you so much, ma'am, for that input. Ma'am, just continuing on the point that you had raised about the evening snacking. Can you give a little more practical tips on what kind of snacking would you recommend for your patients, just for the knowledge for the crowd?
Just for the crowd, when we're having this conversation, we always, again, we encourage one item. And when we are planning for snacks, it includes now planning for main meals. So we encourage our patients, again, not to have what we call the typical breakfast, which in our case, again, will be a starch and a beverage. So tea and bread, or tea and something. So we would encourage them to have a full meal that has a protein, a lot of vegetables, and some carbohydrates. So by the time that they need a snack, we have planned in advance. So when you need that snack, you're not very hungry. All you're trying to do is maintain blood glucose levels. So at that point, they're able to make better decisions. And now this time we tell them you can have a high fiber snack, just a piece of fruit. Right now it's mango season. We tell them when we have a really big mango, we tell them have one side of the mango. They can also have some nuts, because they ate in the morning. It is not very necessary for them to have a very big or elaborate snack. So it can be a piece of fruit, it can be some nuts, it can also just be a small glass of milk, again.
Okay.
So that way they have optimized on their nutrient intake. They're not just taking in a starch, but they have optimized their nutrient intake, their micronutrient intake, as well as now keeping the blood glucose levels in check. Then we also again go back again and inform them about their main meals. Again, the same principle, a lot of vegetables with a little protein and a bit of a snack, a starch. So by the 4 o'clock snack, again, they're not very hungry. Okay. So that way, this particular patient is able to just maintain, they see the snack as a continuation of the previous meal.
Okay.
When we give those guidance. Yes. Thank you so much.
Okay. Thank you, ma'am. That was very valuable, those tips. Taking it towards the Indian scenario on the same thing, I would like to take some tips from Shilpa ma'am regarding the same thing, that how it becomes a bit challenging for these evening snacking to be controlled in this patients. So ma'am, if you can give us some tips.
Okay, so let me first divide patients with diabetes into 3 buckets. So in type 2 diabetes, typically like examples given, maybe a fruit or nut, milk, in Indian scenario, sugar-free tea, not biscuits, not toast, not curry, none of that, but these will work. If you're going to take a person with type 1 diabetes, this will not work. So unless there is a 4 o'clock insulin shot, 4 o'clock, 5 o'clock, 6 o'clock, whenever you want to give breakfast, unless there is an insulin shot, a fruit will not work, a glass of milk will not work. Otherwise, you have to give regular insulin, which will cover it for 4 hours. But even then, you will have the tail of insulin covering the 4 o'clock snack, because it will be typically 4 hours away. So suppose you eat lunch at 12:30, you are not going to snack before 4:30. So your regular insulin is also tapering off by then. But at least there is some life in that insulin. So you might be able to control, say, with nuts. But if you're definitely giving a fruit, you're giving a milk, you're giving a hot snack, leftover breakfast from morning or something like that, you need to give insulin. And I think that is something that people need to understand, that they need to take insulin if they are going to eat, however healthy they eat. So people typically feel, oh, I'm eating only a fruit, why should I take insulin? You will have a very high pre-dinner blood sugar. Now, as far as GDM is concerned, okay, in GDM, you can give a snack even on women who are not on insulin. You can give a snack, but then that snack has to have minimal carbs, because GDM is essentially a postprandial problem. So you will have very high postprandial sugar. So try to give more protein, very little carbohydrate, and you'll be able to manage blood sugar. So I think snacking is very, very individualized. So you cannot use the same principle for type 2 to type 1 to GDM. You will have to look each in their own light in the way they are managed. I hope it answers the question.
Absolutely, ma'am. Absolutely. Thank you so much, ma'am. We'll take a couple of questions even from the attendees also. So how can we understand which meditations would have an effect on blood glucose levels? Is it a meditation or a medication? I'm assuming it might be a medication. So if anybody from the panelist, Dr. Sanjaya sir, if you want to comment on that if there is any drug nutrient interaction that can have an effect also.
Yeah, that with regard to the use of medication, the question?
Yes, sir.
Yeah, actually the diabetic patients type 2, if you have the type 2 patient, normally it started with the metformin, the 500 milligram at night. If that's the patients, especially having the gastrointestinal problems and other side effects due to metformin, after a few days back, we have to ask them to take immediately after meals, or otherwise we have to switch on to the metformin MR, slow sleep or modified release tablets for night. With that one, the doctors will prescribe. Then we have to keep for the patient for 1 month at least to settle the situation. At the same time, for those patients lactic acidosis or something like that, get side effects, then doctors will remove that if you can't tolerate it, even the sustained release form. Then at the DPP4 categories, like other drugs, sitagliptin type of drugs, the slowly adding one by one. That is also we have to, they will give the intervals, keep the interval, because that drugs will take little time to act on the body and the receptors in the body, then slowly will act on that. Then most of the physicians we have seen, the rush into the next category of medication to add on like that quickly. Then based on that dietitian, we have to adjust the very quick, at least 3 main meals and the 4 snacks for the day for these patients. Basically, complex carbohydrate meal to suit their calorie level, to meet their calorie levels for the day, and the 3 small snacks. Sometimes fruits we can shift into the shift into the 3 o'clock and the 10 a.m. at even bedtime. They can have the 1 milk tea without sugar. And at the same time, type 1 patients, normally they will prescribe the insulin, that is the 30-70 or 50-50, or normally basically 30-71 insulin mixed or something. These insulin will normally cover 24 hours, but additional dose they are giving at evening also, every 12-hour gap. For that one, we have to, the dietitian will know to formulate the diet accordingly, then there's no problem. Otherwise, if you can manage patients that way, we can avoid the complication and adding of this one. And this glycemic condition of patients is very important, and the low and as our lecturer said very exactly, DV is very important. Variability of the figure, yeah, that is very important. Based on that, we have to adjust the insulin doses or the meal plans. We have to adjust it if it is patients are at home. Therefore, I think our main duty as dietitian is to give the proper diet, proper counseling, proper calculation, proper quantity of same meal from the same family food. We should not separate from the family these patients. They have to enjoy our same meal. That is our task, how to formulate that, not to increase the blood sugar level. Otherwise, their dyslipidemia level will come, hypertensions, and then more triglycerides level increase. For that, based on that, then doctors will prescribe another medication, adding on one by one and maybe 10 to 12 polypharmacy there. Therefore, our duty is not to add medication to the physician, manage somehow, educate this patient and counsel, education, and give the proper diet and tell them this is the metformin or whatever, this is a basic gold standard medication. This is more than enough. Try and see with this medication initially if the doctors had glucose transporters or some right or various other categories of sulfonylureas or something like that. Then we have to be very carefully manage. Sometimes they will get the hypoglycemic attacks. Then that patient tend to eat. Then again, the doctor will increase the drug dose without consulting the dietitian. Therefore, our duty, we have the main very good responsibility to manage them with the diet,
Absolutely,
Okay.
sir. Thank you, sir. Thank you, sir. You had actually, sir, very rightly pointed out that it's our duty to actually make their load of taking those medications to reduce from our dietetic changes and the diet modifications that we suggest to them. That's very true, sir. Also, in a clinical setup, or rather in a hospital setup, we have also seen that in many of the patients, they might not be a baseline diabetic, but because of the hypercatabolic state also, sometimes hyperglycemia is seen in some of the patients. So my next question is to Bhakti ma'am, that in a hospital setup, in such kind of patients, what criteria do you use to select any kind of supplementation that might help in managing this hyperglycemia for a non-diabetic?
Definitely a hypermetabolic state, we all usually see that the sugars go high even for a non-diabetic patient. But this phenomenon, what we have observed or what I have observed in my practice is post-COVID, there is a sudden increase in this phenomenon where we see a lot of our patients in a hypermetabolic state are having a high sugar. So I think for such patients, when we see that there is a slight increase in the sugar readings, whether on oral diet or on enteral feeding, we definitely try and modify the diet in lines of a diabetic diet. And when we're talking about even oral nutrition supplement, when we are adding on, so there are two main things. One is I'll have to decide on based on the requirement whether I go for a diabetic specific formula or rather I go for a high protein formula where I'm able to manage not just the fat intake, not just the sugar intake, but also the fat intake. So it depends. So if it is a enteral feed formula and depending on my target calorie proteins that I'm looking for, I would preferably do a combination of a diabetic specific formula with a high protein formula to, adjust my protein intake. If it's an oral diet, again here, based on the requirements, I think my selection would go more towards a protein rich formula because I'm able to manage both the things here, the fat as well as the sugar. So I think it is based on the requirement of the total calorie and protein that we would take a call, and it will also depend on the mode of feeding based on which we will take a call. Yeah.
Okay. Thank you so much, ma'am, for that. There was one of the questions from the attendees that can a meal replacer be used instead of a diabetic specific formula for patients who have hyperglycemia but a normal weight? So what can be the selection for these kind of patients? Anybody from the panel can actually answer it. It's an open question.
Can I?
Yes, please.
Please.
Okay. So look at a client, if you're looking at a patient who has normal body weight, but hyperglycemia. Okay. So this is a lean type 2 diabetes. then first you have to find out what is the OHA which is given here. So if the OHA given in a person with lean diabetes is sulfonylurea, giving a protein-rich formula will cause a hypoglycemia later. So in that case, you can give a meal replacement. But if this is a normal weight, but the doctor perceives that insulin resistance is the problem and not insulin deficiency, and still metformin or a gliptin is given, then you can give even the protein supplement. So it really depends upon the holistic management. If it's insulin given, you have to give a meal replacement, if at all, because meal replacement has considerable amount of carbohydrate, whereas protein shake is protein itself. So if you're giving SU, sulfonylurea, you're giving insulin, or you're giving AGI, alpha glucosidase inhibitor, you cannot give just a protein supplement. You need to give a meal replacement. But if it is other things, so say it's a SGLT2 or it's a DPP4, then you can probably give. I don't think you can give it even with SGLT2. You will have to give a meal replacement.
Okay, okay. Thank you so much, ma'am. Ma'am, also, since you had covered the topic of meal replacements, and if the patient has been put on a meal replacer, can it cause a rebound effect also once they stop using it?
So one cannot, one fine day you cannot get up and tell the patient ke kal se band kar do, don't have it for tomorrow. It doesn't work like that. So if there is somebody on meal replacement and say they are on complete meal replacement, taper it. So from 3 meals you go to 2 meals, from 2 meals you go to 1. What is very important is when you start introducing food, it has to be isocaloric with the meal replacement. So suppose your meal replacement is 200 calorie, you plan a 200 calorie meal with similar composition. You will not be able to achieve specifically same composition because you are eating free food, right? But what is very essential is you achieve similar calories. Your composition can change thoda bahut, but your calories cannot change a lot. So say 200, you change 200 and probably go protein rich so that there is better satiety, there is suppression of ghrelin. Once the ghrelin gets suppressed, there is a feeling of fullness. So that is what you can do.
Okay, okay. Ma'am, also there was this one more question in the Q&A box which asked that can use of this meal replacers can trigger any kind of a eating disorder?
I haven't seen any. So I've been using them for I don't know how many years. I don't even know how many years I've used them, and I've never seen an eating disorder happen because I've used a meal replacer. And if you actually review the literature, I do not think we have any data in a peer-reviewed journal which is talking about eating disorders associated with meal replacement therapy. I mean, a trial like direct study, which has been going on for 2 years and huge number of patients and most of them on total meal replacement, we have none reported. We have reports of gallstones and other things, but eating disorder, we do not have it.
Okay, okay. Thank you, ma'am. Also, there's this one question by one of the attendees who has asked that specifically of specific food items like if sweet potato, mango and beetroot can be used and in what quantities can it be suggested?
Is it to me?
Yes, ma'am. If you want to answer, yes, definitely.
So sweet potato, mango and?
Beetroot.
Okay. So if beetroot is a part of salad, so there are some slices of cucumber, some tomatoes, some onions, some carrots, and some beetroot, nothing else. I haven't seen a considerable amount of hyperglycemia happening because of it. Sweet potato, I have seen.
Okay.
And so I have seen with mango. So what is my thing which I tell my patients? And this is, I believe, because of what I have been working on. So if your HbA1cs are near normal, so say they are between say 6.5 to 7.5, so not bad, the impact will be lesser.
Okay.
But if you're already in hyperglycemia all the time, then it will worsen the diabetes control. So again, the same thing what I have been repeatedly saying, you want to eat a mango, now we are going to start eating mangoes in another 1 month. So if you want to eat a mango, do a pre-mango sugar and do a post-mango sugar. And if after eating slices, 2 slices, either end of the mango, 2 cheeks of mango, your blood sugar rose by 100. Then you have to eat 1 slice from the next day.
Okay.
But If after eating 2 chicks of mango, your blood sugar rose by 50, please go ahead and eat it. There's nothing wrong. So it really depends upon what is the variability it is causing. If the variability isn't much, but you will see that if your pre-meal, your pre-mango blood sugar is 200, your post-mango blood sugar will be very high. Because already your blood sugars are high, already there is a lot of decompensation. But say your pre-mango blood sugar is 100 or 80 or whatever, 110, then your post-mango blood sugar being ridiculously high is a smaller chance.
Right.
Okay. And in India, I know there are also audiences from elsewhere, but in India, mango is eaten as a part of main meal as a dish. So they eat something called as amras. And when they eat amras, they eat chapati, they eat puri. Gujaratis also eat dhokla with it. So that whole combination becomes extremely carbogenic, and your blood sugar can even pick up by 200 milligrams per day. So please do not have it as a part of main meal. Have it as a snack and have it in small quantities. And have it sparingly, so you don't have to eat a mango every day. You can eat probably mango every other day.
Okay.
And also there are many varieties of mango. So some mangoes are less sweet than others and probably can cause less postprandial jump in the blood glucose. And then you can choose those mangoes if you want to eat them more frequently. As far as sweet potato is concerned, sweet potato is a big thing eaten in the Western world and a lot spoken about, because in Western world, people are not eating chapati and rice. So sweet potato is what they are eating, right? In India, people eat roti, chawal, sweet potato ka sabzi, and something else. And then the blood sugars go high. So that is the problem. So if you can just, so you understand ultimately, carb is a carb is a carb. That's the principle. All carbohydrates will cause hyperglycemia. So if you can titrate the amount, you can eat it. If you can't, you can't. So if you're snacking in the evening and say you're doing the exercise, workout, you have enough drug in your system. So you have taken whatever SU or, and it's there in your system, you can eat a piece of sweet potato and get away with it. But if you do not have it, you can also, each to his own, do a pre and post and find out.
Okay. True. Thank you so much, ma'am, for that. I would also like to take Christine ma'am's opinion on the same part, the use of sweet potatoes specifically. In if it's being used in your cuisine over there, sweet potatoes or potato or any type of starch. So how do you manage that into your meal plans?
Thank you so much. Yes, in Kenya, we have a lot of sweet potatoes. So, excuse me, most people will take sweet potato as the starch part of either their breakfast or a snack when they're taking it. And a lot of the time we find them taking very big amounts, what we had very large amounts, according as Ms. Shilpa had mentioned. So the very large amounts we have seen, even in small amounts in our experience, we find that the glycemic control is worse with the sweet potatoes, actually with most types of potatoes, than it is now with other whole starches, other whole carbohydrates. So in our setting, we would tend to ask the patient to avoid the sweet potato, but then also we would want to have them self-monitor their blood glucose levels. So if they check and they find that in the week that they were taking their snack measurements, you remember we were taking every week a different measurement, a different parameter. So in the week that they're taking their snack measurements, or their breakfast measurements, they would notice that their blood sugar has spiked because they have been taking a sweet potato. So we would encourage that patient to stop. Don't take the sweet potato. But then we have those patients who are taking and their blood sugar levels remain constant. There is no sudden rise in blood sugar. Then this is the type of person that can continue taking. We want to emphasize that diabetes management is very, very extremely individual. It is not one size fits all. Thank you so much.
True. Thank you so much, ma'am, because we have seen patients from Kenya who have a lot of starchy foods that is included into their meals. So yes, it's a very important point that it had to be brought up. So thank you so much for that. There's this one question in which an attendee has asked that if the patient who is admitted in the hospital and is suffering from diarrhea, so what kind of a snack or a bedtime snack that can be given to this patient specifically? And in continuity to the same question, if this also affects the selection of a particular supplement for these patients. Bhakti ma'am, if you can give your inputs on that.
So talking about supplementation for these patients, I would say like what Shilpa very rightly pointed out when she was doing a presentation, in such cases where I'm not able to meet up my protein requirement, only then I would resort to giving a supplement. If I'm giving a supplement, definitely, if we are looking at diarrhea, at that point of time, giving a semi-elemental, which is without any sucrose added, is what we will look at, because a lot of the semi-elemental supplements, there are a lot of brands available which do have added sucrose, though a very small amount. But if I'm looking at my sugar control, definitely my I would select a semi-elemental which does not have any added sugar. That is one. Looking at the meal part, I think more than the bedtime snacking, overall, obviously, when you're looking at diarrhea, you have to, if you're going to give a lot of rotis or a lot of gluten in the diet, it is going to aggravate. At such time, when we are incorporating maybe, say, rice preparations, you have to see to it that you are giving enough of protein also, maybe in the form of yogurts or maybe in the form of, soluble fiber, which is given along with the meal to manage that diarrhea. Because you can't be telling a patient who is maybe having multiple episodes of diarrhea that no, you have to still continue eating a roti and you cannot eat a rice. So your management is going to vary, because at this time your priority is first to manage the diarrhea. Once the diarrhea is better, then you look at even the blood sugars as such. So semi-elemental is what I'll go with in such situation, and I would definitely try and incorporate rice or rice-based snacks just to help and control the diarrhea. But I have to do it in combination with a protein. Adding on to the starch part that we were talking about, the sweet potato, like very rightly pointed out, that when we Indians eat it, we will eat it with roti, bhaji, along with that a sweet potato, there will be a rice, there will be a dal, everything together. But if you're going more like on a continental meal side, where you would give more of a protein as a meal, only the carb component, the certain percentage of your carb component is coming from sweet potato, is not going to have that much of spike versus a rice and a sweet potato and a roti and a meal. So I think that is how we would manage.
Okay. Thank you so much, ma'am, for that input. I have this one query. If Shilpa, ma'am, if you can answer that what is the role of supplementation, especially for a GDM patient? As in, what best time would you suggest if in case we want to use a supplement for their additional protein need or anything? What can be the best time when we can include this kind of supplement for them?
So remember, in 95% of GDMs, early morning sugars are a mess. So fasting sugars are a mess because of the counter-regulatory hormones which are secreted by the woman, along with other kind of progesterone and other hormones. So typically what is said is, when you're planning a meal for a woman with GDM, you do not, with or without insulin, especially one without insulin, the first meal you never give carbs. If you give carbs in the morning in the first meal, the cortisol secretion is high and the postprandial response of the first meal is very high. So if you want to give a protein supplement which does not have much carbohydrate, so a classical protein supplement if you must, or try not giving it in milk, it will have to be given in water, or you might want to give just egg whites or eggs, depending upon what is the weight gain profile. It's a good thing to start day with the protein, because that is a time when you can't give carbs. And for most of us, if you can't give carbs, then what do you eat? Yeah, there is nothing to eat if you don't give carbs. So a lot of times, first meal is a problem, and first meal is a good time to give protein to bridge the gap in case of women with GD.
Okay, okay. Wow, thank you so much, ma'am. That was very, very valuable. That was a very valuable and a very practical tip also. Also, there's this one more query that I have that anybody from the panel can actually look into it, but this is more towards the hospital admitted patient. As also in the Shilpa ma'am had covered this point even in the presentation, but specifically I wanted to raise it again that if in case there is something like a rebound hypoglycemia for a critically ill patient specifically who's on an enteral feeding, and if the patient is consistently having hypoglycemia, even if the patient is a diabetic, so what management techniques can we use from the dietary point of view for such patients? Ma'am, anybody from the panel can actually give their inputs.
See, when you're looking at enteral nutrition or patients who are on enteral nutrition, most of the hospitals will have a policy of either doing a 2-hourly feeding or a 3-hourly feeding, or it can be a continuous feeding. In such situations, I think doing a continuous drip feed rather than a bolus feeding or an intermittent feeding would work better. Because here there is a slow, you are giving whatever nutrition that you are giving at a very slow rate throughout the day. So I think that can be managed better. And if it's a 2-hourly or a 3-hourly feeding, then adjusting your protein intake in those meals, looking at your protein delivery in each of these, also the calorie delivery, that each feed should be isocaloric. It shouldn't happen that one feed is giving you, say, X amount of carbohydrate and calories, and the other feed is giving, which is going to be placed after 2 hours or 3 hours, is going to have, say, one will have 100 calories, the other will have 200 calories. So that is one thing that we need to look at, because we do come across a lot of, so like in our center, that we would give a complete scientific formula. So we know that each of our feeds are going to be of the same calorie, protein, carb, this thing. But then especially hospitals where you're giving blenderized feed, so that's where you will have to look at your carbohydrate content, your protein delivery, and best would be in such a situation to do a continuous drip feed, and you will see that you'll be able to control that situation better.
Okay, thank you, ma'am. Also, I would like to take on the same line some inputs from Dr. Sanjaya sir also, that how important would be the role of fiber specifically in this kind of patients in if they are having a early morning hypoglycemia. So what role the fiber can play in this kind of, or rather in this kind of a feeding pattern? If you can give your input, sir.
Yes, actually the diabetic management, the very, very important part of the diet is the fiber, whether it is soluble or the normal fiber. This fiber is delay in the gastric emptying, and we can retain the meal more than 4 hours per main meals, the better. Therefore, even for the night meals, now I have listened to Indian dietetic culture and the Kenya dietetic culture, for they are completely mainly the less fiber, more carbohydrate type of diet. Based on that, maybe more protein. But however, if you can't have add in more fiber type of vegetables incorporate into the meal, maybe boiled or content, some fiber content meal with the carbohydrate, low carbohydrate uh, quantity, incorporate with that correct protein levels, definitely we can manage the fasting blood sugar levels, as our uh, Joshi madam also said correctly. The fasting blood sugar level we have to manage very well for those patients. If you can manage that one, definitely we can manage the rest of the day. Otherwise, if the patient add on the morning meal also with the normally most of the here in Sri Lankans used to take the nowadays more carbohydrate type of meals, less vegetables. That's the pattern. Then increase again the sugar level, the spikes will go up, the postprandials. Then again the drugs Then after meals, they will take it the meal or the insulin at that time. Then again, we have to, for about like 10 o'clock, they will tend to eat something else. Therefore, I think try to incorporate, and we have to develop the culture somehow to incorporate more vegetables, greens and vegetables to our meal recipes. That is very, very important.
Okay, okay. Thank you so much, sir, for the input. So we have one more question over here. There are a couple of questions. So one is, would you consider fruit and cheese a good snack combination, or is fruit and nuts a better combination?
Yeah, actually, I think compared to the cheese, fruit and nuts is better combination because fruits give the MUPA and monounsaturated fatty acids more content to there. At the same time, fiber also will contribute to that one. At the same time, fruits also contribute soluble fiber there rather than the cheese. Cheese will contribute to more saturated fat. I think the better, my opinion, personal opinion, fruits portion with the nuts the best.
Is much better. Okay, sir. Okay, sir. Shilpa ma'am, I have a question for you. That one of the attendees have also put it up that during the fasting days, we tend to consume a lot of starchy food items. That is one. The second part to this also continuity to the question is, if in case these diabetic patients fast for a longer period of time, so what kind of options can we give it to them, and whether if meal replacers are used in such kind of scenarios, or are they ready to use a meal replacer if they are going to be fasting for long periods, and if they are okay taking a snack in the middle? So, ma'am, what's your professional opinion on this?
Yeah, so fasting in a person with type 2 diabetes on therapy is driven by the therapy. So, like I said, if they want to do something like a IF, time restricted feeding, so they say that, we will not eat anything till whatever, 1 o'clock, and we will eat after 1. Then if there is an insulin SU in the morning, you have to talk to the doctor and get the dose adjusted. That's the prime thing. So fasting is not for everybody. If you choose to fast, you first speak to your healthcare provider, adjust your doses, and then start fasting. That's the first thing. Second thing is Indian Hindu fast will allow a lot of foods to be eaten. Okay, where most of the foods, like rightly put, are starches. So basically root tubers are eaten, fruit are eaten, and starchy grains like tapioca, that is sabudana, or different kinds of other starchy grains are eaten. So my opinion is again that a lot of vegetables are also permitted. So each community eats its different kinds, but there are considerable. So use the ADA plate method of eating. Fill half your plate with vegetables, cooked or raw. A fourth of plate of protein. Now, paneer is eaten in fasting, curd is eaten in fasting, so they can be your proteins, and only a quarter plate of carbohydrate, if at all. If it is Ramadan fasting, where there is no fast, like there is no food, then you really need to readjust your insulin or OHS to suit your Sahari time in the morning and your breaking of the fast in the evening. And again, the same principle of standard eating: half plate of veggies, a fourth plate of protein, and a fourth plate of carb. This will ensure that the carb intake is limited. So you might still eat carbs, but they will be distributed in 2 to 3 meals rather than eating sabudana, potato, sweet potato, everything in one meal. So try to distribute it equally. But the main important thing is, if you want to fast, please adjust your OHAs and insulin before you get into it. Otherwise, risk of hypoglycemia is very high, because not all patients are aware of which medication are they taking. They do not know whether it's a sulfonylurea or alpha glucosidase inhibitor or a gliptin they don't know. They basically call it medicine, right? So it's rather than using your speculation, it's better you go to your healthcare provider, adjust the doses, and then sort of use the plate method of eating.
Okay, okay. And ma'am, what's your opinion about the meal replacer usage
So
in
if
this?
they are ready to use meal replacer, a lot of people will not use meal
Yeah.
replacer because it is fast. So they are really not sure about what is it that is put in meal replacer. Although most of them are marked as green, they are green dot. But a lot of people will not. If they can use, great. There's nothing better than that. But
Okay.
out of 100 people, 98 will not use it.
True, true. So, ma'am, if the patient is a diabetic and they want to fast, so you, in a professional opinion, do not stop them from fasting.
No.
It's
You
their
can't.
personal
So
choice.
ADA standards of care first says that you cannot interfere with life of patient. You have to let them lead their normal life, let them have their religious beliefs, because see, ultimately we are doing all this for quality of life. We are not doing for the length of. They have to feel good when they are living. So if fasting means so much to them, they need to fast, but they need to adjust their medications to suit that fast.
True, true, ma'am.
Hello,
Because in a
Shraddha.
yes, ma'am.
Sorry,
No
I
problem.
just want to ask one question. First, you ask yours, then I will ask.
No,
one
ma'am.
question.
Please continue, ma'am.
Yeah. So I have this question for Shilpa. I just want everybody to know her input on that. Many a times, what happens in hospital setup is when patient is vegetarian, and we want to add a protein supplement because patient is vegetarian, has undergone some amputation or whatever his protein needs are very high. Now, normally what we do is we ask them to have this protein supplement, say maybe with milk in the breakfast menu. Yeah, whatever. Now, on most of the occasions and not, the endocrinologist is very much against it because these supplements are hyperglycemic because they are in powdered form. So, what is your take on that? What will you, what are your comments on that?
Sorry, the question was for me, but I did not understand. Yes. Was the question that should you add protein powder to milk? Was that the question?
No, my question is what one should be doing in such a scenario, because then the endocrinologist will not allow the patient to take the protein supplement, saying that it is hyperglycemic because it causes postprandial, rise in blood sugar. So, what will you suggest and what is your comment on that?
So what happens is in hospital scenario, because of a lot of catabolism, gluconeogenesis is very high. So even when you are giving protein per se, protein is converted into glucose and then the blood sugar rises. And that is why a lot of times in hospital, even though you are giving plain proteins, they're still causing hyperglycemia. At that point, try to give dietary sources. I understand vegetarian dietary sources are very poor. They are very few, but wait for the patient to settle. It might take a day or two, or then if you can talk to the endocrinologist, up the dose of insulin a little bit. If you see that the patient is just not able to eat. See, the problem with vegetarian sources of protein are they are bulky. So how much dal can you eat? One katori?
Exactly.
Two
and
katoris?
It is so high in carb also.
Correct. And they're very bulky. They make you full and gaseous.
Yes.
Yeah. So then you talk to the endocrinologist to increase the dose of insulin because there is no other way out and give. But more often than not, what happens is a gluconeogenesis being high, a plain protein supplement can also cause increase in blood glucose. So that's the reason. And so in such times, eggs become very easy. But if it's a strict vegetarian patient, you can't give eggs.
Exactly.
And yeah. So you can. That's the only way you can give.
Yeah, I would just add on one point, ma'am. At such situations, like I even pointed out before, timing this supplement at the right time can help us change this. So what we normally do is then we would minus a mid-morning meal and tell the patient that you take the ONS, whether it is a diabetic specific or a high protein formula. So we adjust it and we minus any meal coming along with that. So maybe a mid-morning meal or maybe in the evening time. So at those times we tell the patient, because patient is not eating any breakfast snack or any lunch meal or a dinner meal, because if we are going to time it very close to a major meal, is where we have also seen, even with the diabetic specific formula, it is going to increase the sugars. So I think in such cases we only try and adjust the timing of the meal. I think that the timing of the ONS, that really helps.
Thank you, Bhakti, and thank you, Shilpa, for your input.
Thank you, Joshi ma'am, for such an important question. With this, we would like to close our panel discussion, because this is such a topic that even it goes on for 24 hours, still the questions won't stop. We have a lot of questions still pending into our Q&A box, and we will try to answer all of them post this session as well. So thank you all the panelists for such a valuable time and inputs that you all have given us, because these are so important in our practical experience, and when we are dealing with these patients to day, be it in the OPD basis or be it even in the hospital admitted patients, because every person is different, every diabetic is different, and with so many medications and with so many comorbidities working together, managing them becomes very challenging. But when you know that you are on the right track and you have the correct knowledge, managing of these patients and their blood sugar levels becomes much more easier. And I'm sure that today's session has contributed a lot to this knowledge base of ours. So thank you once again to all the panelists for such a great, valuable inputs that you all have given us today. And just a quick note for the attendees also. The feedback link for all the 9 sessions have been posted in the chat box. So please look into the chat box. Also, the link for the recorded sessions have also been put over there. So do not miss out on that. And yes, there is an exam link that's going to be posted, but that's going to be posted next Wednesday, which is on 8th of March. That is our day. That's the Women's Day. And we have the most important topic on that day, which is scientific weight management. I'm sure many of the dietitians are going to be giving talks on the Women's Day on this topic. So don't miss out on the 8th March session as well. It's going to be as interesting as all the sessions. So thank you so much. Enjoy your evening.
Thank
Thank
you.
you. Good night.
Thank
you.
you. Thank you.